Good morning, everyone. I'm very happy to start this meeting, and I'd like to thank our international guests and speakers, Professor Christina and Professor Masoud, for giving us the honor to be with us today. And I would like also to thank the national guests from all over Egypt. Thank you for coming. Today I'll start my talk about the hidden faces of migraine. So I'll start, being in Egypt, I'll start with the history. So the diagnosis of headache and especially migraine has been described 1,000 years back. So they used a clay crocodile and they put a magic herb in his mouth and then bound this to the head of the patient trying to treat their patients. Digging in the history, I found this paper that was published in Kephalalgia 2001, and it was dealing with the headache in the medical papyri. This is the papers that the ancient Egyptians used to write and document everything. And they said that, asked, was Kephalalgia a common alignment in ancient Egypt? From 900 prescriptions, actually they found 13 out of these dealing with headache. And they said that it could be concluded that headache were common and well known in the ancient Egyptians. Egyptian physicians actually divided headache into 4 places. They localized headache at that time in 4 places. Either this headache is head or skull in general, or it's half of the head affecting the temple or the nape. So all of us know that migraine affects 1 billion people. And the problem is it's one of the leading causes of disability in younger than 50 years, with a prevalence of 15% of the general population. According to the Global Burden of Disease study, we can find that migraine is the 2nd most prevalent neurological disease. And as we can see in this figure, it's before epilepsy, MS, and motor neuron disease. So we have to deal with migraine as not simply a disorder of a recurrent pain attacks, but it's actually a complex and multifaceted neurological disease. As we all know, it has 4 phases, starting from the prodrome, the aura, the headache phase, and the prodrome, each of which is included in the region of the brain is affected by different forms, and each of them have different symptomatology. Although headache is the main symptom, but also there is a plethora of non-headache symptoms. Such non-headache symptoms will include the need to go to bed rest, the functional impairment, the family activity distortion and social activity, the stigma that the patient receives from the non-migrainous patients, and the comorbidities the patient face with the cost so direct or indirect cost. So patients experience at least 1 non-headache symptom. And it's very important to clarify that this area is very interesting so that we might clarify the mechanism of migraine attack initiation for better management of our patients. One of the hidden faces of migraine is the use of medication, that the patient has more headache. So more headache means higher attack frequency, and this means that the patient will have higher intake of acute treatment management with increasing risk of medication overuse headache. The next lecture will be given by Professor Christina, and she will just highlight the importance of medication overuse headache. So the problem of medication overuse, or this phase, is the vicious circle the patient enters. More headache, more medication, and so on. The problem in Egypt that we face, that medication overuse headache is very common because of the over-the-counter use of analgesics. The patient can go by themselves without any prescription and start taking triptans or ergots. The non-headache symptoms of migraine include the mental state, which includes depression, anxiety, fatigue, agitation, confusion, or hypomania. The neurological manifestations, including blurring of vision, vertigo, dysphagia, syncope, and paresthesias, and the general manifestations, which include the autonomic manifestation, neck stiffness, and food craving. As we all know, the migraine phases are included in 4 phases: the prodrome, the aura, the headache phase, and the prodrome. I will start with one of the hidden phases of migraine, which is the prodromal phase. So what's the definition of prodromal phase? According to the International Classification of Headache Disorder, and we have 2 presidents, the past and the present president of the International Headache Disorder. So the symptom, we have to be very strict to the guidelines. So they mentioned that it's symptoms preceding and forewarning attack of migraine by 2 hours up to 2 days. And they recommended using the term prodrome rather than the premonitory symptoms. But while preparing this talk, I found that nobody is strict to this. So the prevalence of a prodromal phase is a very huge and very big range, starting from 9% up to 87% across the studies. And this different epidemiological studies, as we can see, due to the different study design. Some designs are retrospective, others are prospective, some are questionnaire related or face-to-face designed. The main groups of symptoms in the prodromal symptoms include the cognitive and mood, the hormonal changes, the hypersensitivity, including allodynia, and the cranial autonomic manifestations. But we have to remember that these symptoms will last up to 2 days. And during these 2 days, the patient are not suffering from migraine. That's why often these symptoms are not recognized by the patient, and they significantly impact the quality of life of those patients. The presence of at least one prodromal symptom is generally considered sufficient to define this phase. These symptoms are due to the activation of the cortical and subcortical structures. As we can see, the hypothalamus is one of the very commonly studied regions. They found that fatigue, mood changes, yawing, and food craving was related to the orexin, dopamine, and the neuropeptide Y due to the involvement of the hypothalamus. But actually, the neuroimaging is increasingly used as a tool for investigating the origin of the prodromal phase. They found the hypothalamus in many studies involved, and the new studies using the functional images showed that not only the hypothalamus is the area to be blamed, but the trigeminal, pontine, and the thalamocortical pathways. These are also affecting during the headache phase, not only in the prodrome, and this is the continuum of the manifestations. When they compared the imaging findings of the premonitory phase, they found that the dorsal pons is the most affected part for the prodromal phase, followed by the ventral tegmentum, hypothalamus, and the spinal trigeminal nucleus. But here comes the debate. Is it only the hypothalamus? This paper was published by Golian in Headache Journal 2020, early in this year, and they debated the hypothalamus because of the limitation of their studies. Although they used functional imaging, but also they found that the number of the patients were very low, or the comparison method or the lack of definition was there. So there are a lot of cross-sectional studies studying the premonitory phase symptoms. One of them is the Finnish people, included 2,714 patients. They found that yawing, mood changes, and lethargy were present in almost 30% of the patients. And at least one symptom was present in 17 patients, while we can see in this figure on the right side that there is some patients reporting 9 and 10 symptoms. Across this study, they also found that the measure of the headache severity, frequency, duration, intensity, working capacity were related to the higher incidence and burden of premonitory symptoms. In another bigger study, a cross-sectional study in China that included 4,821 study, they found that 21% of their patients had at least one. So they have more than one. And this most common symptoms included dizziness, neck stiffness, yawing, and drowsiness. And they found that the more the patient experience were related to the medication, to the migraine with aura, the triggerer, depression, and the consumption of coffee. This is a very nice systematic review done by Professor Masoud Ashina, just published November 2022 in Headache. And it was the first systemic review and meta-analysis of observational studies reporting these premonitory symptoms. And they reported that the pooled relatively frequency was 66% in clinical-based studies, while the pooled prevalence in population-based was only 29%. The three most common symptoms were fatigue, neck stiffness, and mood changes. But they reported that these estimates should be interpreted with caution, owing to the inconsistent definition, methodological difference, and the heterogeneity of these studies. This paper is very nice, tracking the non-headache symptoms all through the headache phase, not only in the premonitory phases. And they found that it's a continuum. It's not just a sequential, but it's an overlapping manner. The changes are all through. It starts with one phase and continues to the other. I will start with the second phase, or the second hidden phase, which is the prodromal phase, the postdromal, This postdromal is the symptomatic phase that lasts also 2 days, following the resolution of pain and migraine attacks, whether it's with or without aura. What's meant by headache resolution? It means that the patient feels completely back to normal, and it's very, very difficult that the patient can define that he is back to normal. The post-drome includes 4 subtypes: the neuropsychiatry, sensory, gastrointestinal, and general, and it was suggested that the more the headache, the more the post-drome symptoms. We just mentioned many tables concluding the functional and neuroimaging of patients with pre-monitoring symptoms, but this is very, very deficient in the post-drome manifestations. Why? Because patients, once they feel free of pain, they don't want to remember anything. It's have been finished. So they don't want to remember that there was any symptoms, including the post-drome phase. But being tired was most the common symptom reported, mainly in 88% of the post-drome, with other symptoms like difficulty with concentration and stiff neck. Do we miss the atypical migraine? This is other side or other face of migraine. The other side not involving all, but this is one of the most important types of the atypical migraine, like typical aura without headache, and this is very commonly seen. Typical migraine with brainstem aura and hemiplegic migraine and others. The problem in aura without headache, or previously called acephalgic migraine, is that the patient experiences only the aura without the headache, and this represents 3% in the females and 1% in males. By definition, it's migraine with typical aura as the usual diagnostic criteria we use, but no headache accompanies or follow the aura within 1 hour. So the patient experiences a lot of manifestations during this aura without headache. It usually lasts from 15 to 30 minutes, but sometimes it recurs more than 1 time in the same day, and it's triggered by the same triggerers like migraine with aura. Another hidden face of migraine which affects the quality of our patients is the absenteeism rate, which means the number of absent days delivered by the number of available working days in a total period. And actually, this is one of the 10 most disabling medical disorders in migraine due to the absenteeism. The presenteeism is different. It means that the patient is in work, he is working while sick, and it leads to a lost work time than absenteeism. Patients with chronic migraine was found to have 4 times more productive time lost compared to the non-migrainous patients, and this would represent 16% of the total US workforce presenteeism. This table shows the economic loss for the persons with due to absenteeism and presenteeism, and as you can see, the migraine is one of the most common causes of economic loss. 1/3 of the migraine attacks occur on working days, and that's very serious. 2/3 of these attacks will result in substantial loss of productivity. In one study, they found that the baseline reduction in the migraine productivity, the patient productivity, was reduced 54% after 6 months. People were less confident, they have less productivity, negative impact on their social life, and they have the stigma of being migrainous. So it's very important for us to listen to the patient. Quite often, he's telling you the diagnosis, and the diagnosis is not only for the migraine attack and the headache description. It should also include the pre-monitory symptoms and the post-drome. So the take-home message is proper history taking for all migraine phases and not the headache only. The headache diary is mandatory in our patients because it will point to all the manifestation and the phases. The migraine attack can last much longer than the pain as we think. Identify the ugly face of migraine as a complex disease and not only as headache pain, and also understanding the stages to improve the research and the therapies. So when looking to this face, we have to identify the most of it, not only the clear image. This is from a workshop, the headache Cairo workshop yesterday in headache. It was having a lot of attendees from other governments. It was a very successful one. And thank you.